Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. This is Rebecca Jane Collins. Merci de nous avoir rejoints aujourd'hui sur la chaîne Anesthésie et Médecine Périopératoire.
本日は麻酔・手術器医学チャンネルにご参加いただきありがとうございます。
Today, we're diving deep into a topic that truly sits at the crossroads of critical care, surgery, and some profound ethical considerations: our role as anesthesiologists in organ procurement. In this unique setting, you are, in every sense of the word, the guardian of physiological stability during one of the most complex and delicate processes in all of modern medicine. So, to really understand why this matters so much, let's start by framing the problem. This graph, well, it tells a pretty stark story. You can see over a 25-year period in the US, the waiting list, that's the purple area at the top, has just climbed and climbed relentlessly. But then look down at the bottom. The blue and green lines, which represent actual transplants and the number of donors, have stayed almost flat. This huge, ever-widening gap isn't just a data set. It represents a real crisis of unfulfilled hope for thousands and thousands of patients. It's this gap that drives every single innovation and every challenge we're about to discuss today. Now, in an effort to bridge this critical gap, clinical practice has had to evolve quite dramatically. One of the most significant shifts has been the rise of something we call donation after circulatory death, or DCD. Here in the UK, for example, this pathway has become an absolute cornerstone of donation, now accounting for nearly 40% of all deceased organ donations. This has been absolutely instrumental in expanding the donor pool. But as we're about to see, it also introduces a completely different set of physiological and, indeed, ethical puzzles for us as clinicians to solve. So here's the roadmap for our session. We've just touched on the crisis. Next, we're going to dissect the two main donor pathways, DBD and DCD. Then we'll define your critical management goals in detail. After that, we'll explore some of the amazing new preservation technologies that are changing the game. We'll also touch on the unique challenges of managing living donors, and finally, we'll spend some time calibrating the ethical compass that really must guide every single decision you make in this field. All right, let's get into the nitty-gritty of the two primary pathways: donation after brain death and donation after circulatory death. Now, the differences between these two are absolutely fundamental. They dictate completely different physiological cascades, and, as a result, they demand entirely distinct anesthetic strategies. Your approach to a DBD donor is going to be radically different from your approach to a DCD donor. So the fundamental difference really boils down to how death is declared. In donation after brain death, or DBD, death is a neurological event. The heart is still beating, and we use life support to maintain circulation. This is key because it means the organs remain perfused with warm, oxygenated blood. In this scenario, our main battle is against the systemic collapse that follows the loss of central regulation from the brain. In stark contrast with donation after circulatory death, or DCD, death is declared after the heart is stopped. This involves a planned, controlled withdrawal of life-sustaining therapy. Because of this, the organs are inevitably exposed to a period of what we call warm ischemia. And here, our primary battle is against time and the ischemic injury that follows. So let's focus on the DBD donor first. When you're managing a DBD donor, you are quite literally navigating the systemic chaos that follows the irreversible loss of all central regulation. The brain's control over every bodily system is gone. This triggers a catastrophic, multi-system cascade of events that, if you don't manage it, will very rapidly render the organs non-viable. Your role in this moment is to become the external regulator, to impose order on this incredible physiological storm. Brain death triggers what can only be described as a catastrophic multi-system failure. It's not just one thing going wrong, it's everything, all at once. The cardiovascular system swings wildly from an initial phase of extreme hypertension to a state of profound shock. The endocrine system completely collapses, leading to diabetes insipidus in up to 90% of donors, a staggering figure. You see a complete loss of metabolic control, runaway inflammation, and even coagulopathy like DIC. Your job is to fight a war on multiple fronts, simultaneously, to preserve these precious organs. Let's focus in on that cardiovascular response for a moment, because it's a real challenge. The first phase is often called the autonomic storm. As intracranial pressure skyrockets and the brainstem is crushed, the body unleashes a massive sympathetic discharge. This causes intense vasoconstriction, tachycardia, and a severe hypertensive crisis. This storm can be so violent, it can cause acute myocardial injury, even in previously healthy hearts. But then, following this storm, the second phase begins. The spinal cord infarcts, the loss of sympathetic tone is complete, and this leads to profound and sustained vasoplegia and hypotension. Managing this wild swing from one extreme to the other is one of your central challenges. The endocrine collapse is particularly devastating, and it often starts with pituitary failure. The loss of antidiuretic hormone, or ADH, leads to central diabetes insipidus. This can result in massive polyuria, we're talking liters per hour, which in turn causes severe hypovolemia and hypernatremia if it's not managed. This has to be treated aggressively with careful fluid replacement and desmopressin. At the same time, hypothalamic failure means the body can no longer regulate its own temperature, quickly leading to hypothermia, which itself impairs coagulation and cardiac function. Now, let's switch gears and move to DCD. The physiology here is completely different. We're no longer managing a body and systemic collapse while the heart is still beating. Instead, we find ourselves in a race against the clock that begins the very moment circulation ceases. The primary challenge completely shifts from managing that systemic collapse to minimizing the duration and the impact of warm ischemic injury on the organs before they can be recovered and cooled down. This structured process is absolutely critical, both for ethical integrity and for clinical success. And I want to stress this first point. The decision to withdraw life-sustaining therapy must always be made entirely separate from and before any discussion of organ donation. A critical step in the process is the standoff period, typically 5 minutes here in the UK, after circulatory arrest is confirmed. This is a mandatory wait to ensure that autoresuscitation doesn't occur. Only after this period has passed can death be formally declared. This stricter protocol is essential for upholding what's known as the dead donor rule, which we'll explore in more detail later.
The big unknown in any DCD case is timing. Will the patient arrest quickly enough for the organs to remain viable? If the process takes too long, prolonged ischemia will render them unusable. Tools like the University of Wisconsin score have been developed to help predict this. It synthesizes a number of clinical variables, like the patient's respiratory drive and their need for vasopressors, into a score that gives the team a probabilistic assessment. Now, this isn't about being perfectly predictive, it's not a crystal ball, but it's about managing expectations for the family and for the surgical teams who are waiting on standby.
So this brings us right to the core of our role in this process. As the anesthesiologist, your management directly and profoundly impacts not just whether organs can be procured, but their quality, and ultimately the outcome for the recipient. You truly are the perioperative guardian of these precious life-saving gifts. So let's be absolutely clear on this. Every single intervention you make, every fluid bolus you give, every tiny pressor adjustment, every ventilator change, it all has one single overarching objective: creating the optimal physiological environment for the donor organs. You are fighting against that pathophysiological cascade of brain death to artificially maintain a state of homeostasis that no longer exists naturally, all to preserve organ function until the moment of procurement. And these are your specific clinical targets, often referred to as donor management goals, or DMGs. They are not arbitrary numbers. Hitting these targets, keeping the MAP in that sweet spot, the sodium in check, the urine output robust, is often the difference between procuring one organ or procuring multiple. When bundled care protocols that focus on achieving these goals are implemented, studies have shown a significant increase in the number of organs transplanted per donor. This is evidence-based organ preservation, and achieving these goals directly translates to more lives saved. It's as simple as that. So let's think of this as your pre-procurement checklist. For hemodynamics, we're targeting that MAP, preferably using balanced crystalloids to avoid hyperchloremic acidosis, with norepinephrine as our first-line pressor. For ventilation, a lung protective strategy with low tidal volumes and appropriate PEEP is absolutely essential to maximize the chances of lung donation. On the endocrine front, as we've said, we're treating DI, we're managing blood glucose, and we're considering thyroid hormone replacement for refractory hypotension. And of course, fundamental to all of this is maintaining normal thermia and normal coagulation. Right, now let's look at how modern technology is really pushing the boundaries of what's possible, especially when it comes to recovering DCD hearts, which until very recently were considered entirely unusable. This is where the field is evolving at a truly breathtaking pace. The journey of DCD heart transplantation is actually a fascinating story. Believe it or not, the very first heart transplants in the 1960s were, in fact, DCD transplants, performed before brain death was a legally established concept. The practice was then abandoned for decades, but as the organ shortage worsened, interest was renewed in the 2000s. But the true game changers came with technology, First, the development of ex vivo perfusion in 2009, and then the landmark programs at Royal Papworth here in the UK and St. Vincent's in Australia, which pioneered the techniques that have now made DCD heart transplantation a clinical reality. Today, there are two main strategies for retrieving a DCD heart. The first is called direct procurement, or DP. Here, after death is declared, the team works as quickly as possible to get in, explant the heart, and cool it. It's very similar to a standard DBD procurement. The alternative and much more complex method is normothermic regional perfusion, or NRP. In this case, after death is declared, cannulas are placed and circulation is restored just to the thoracic organs in situ, using an ECMO circuit. The incredible advantage of this is that it allows the team to resuscitate the heart inside the donor's body and actually assess its function after it's taken that warm ischemic hit before they decide to proceed with the transplant. And this really illustrates that the modern approach to organ preservation is completely modular. It's no longer just about putting an organ on ice in a box. We now have this whole toolkit of options, like using regional perfusion in the donor, machine perfusion during transport, or just direct procurement to cold storage. The goal is to create a bespoke, customized preservation pathway for each individual organ, combining techniques to minimize that ischemic injury and maximize the chances of a successful transplant. One of the key technologies enabling all of this is the organ care system, often called the heart in a box. This is a portable ex vivo perfusion device. So instead of being cold and static on ice, the donor heart is placed into this machine where it's perfused with warm, oxygenated blood, and it continues to beat during the entire transport. Now, crucially, this allows us to assess the organ's viability in real time by monitoring metabolic parameters like lactate. A dropping lactate level, typically aiming for below 5 millimole per liter, indicates the heart is metabolically recovering and is very likely to function well after the transplant. But despite all these amazing technological advances, there's still significant variation in protocols around the world. If you look at the leading centers, you'll find different rules on preemptive transfusions or giving heparin before withdrawal, different definitions and time limits for warm ischemia, and even different standoff periods. It really just highlights that this is still a rapidly evolving field, where best practices are being refined in real time through clinical experience and international collaboration. We're now going to shift our focus away from deceased donors and look at the unique considerations for living donors. Here, our primary responsibility is twofold. First, ensuring the absolute safety of a healthy individual who is undergoing a major operation for purely altruistic reasons, and second, optimizing the quality of the donated organ. We'll also address the universal challenge that affects every single transplanted organ, ischemia-reperfusion injury. For a living kidney donor, our anesthetic management is centered on donor safety and graft optimization. While the mortality risk is incredibly low, it is not zero, with pulmonary embolism being a primary concern we must guard against. To optimize the graft, meticulous fluid management is absolutely key. We need to maintain euvolemia and a robust urine output, often targeting over 2 mL per kilo per hour. This can be challenging during a laparoscopic procedure with pneumoperitoneum, so we often advocate for the lowest possible insufflation pressures to avoid compressing the renal vessels and impairing perfusion. Living liver donation, however, is a different ballgame entirely. It's a far more complex and higher-risk procedure for the donor. Data from large series show a significant complication rate, with nearly 40% of donors experiencing at least one issue. From our perspective, this is a major hepatectomy in a perfectly healthy patient. You have to be prepared for major fluid shifts, the potential for significant blood loss, and you need to perform meticulous CVP management to minimize bleeding during the parenchymal transection, all while ensuring there's adequate perfusion to the remaining liver. It demands an incredibly high level of vigilance. Now, ischemia-reperfusion injury, or IRI, is the unavoidable final hurdle for every single transplanted organ. It's a truly paradoxical phenomenon. You see, while the ischemia depletes the cells of energy, it's actually the reintroduction of oxygen upon reperfusion that triggers the most significant damage. This reoxygenation unleashes a massive inflammatory cascade and a flood of reactive oxygen species, or free radicals. For DCD organs, which have already endured a significant period of warm ischemia, mitigating IRI is a primary goal of all the modern preservation techniques we've just discussed. And finally, let's address the profound ethical dimensions of this work. As anesthesiologists at the absolute heart of the procurement process, you are confronted with some incredibly complex moral and professional questions. The clinical skills required are, of course, immense, but they must be guided by an equally robust ethical compass. This rule is the ethical bedrock of all deceased donation. It is a bright, uncrossable line, and it's absolutely foundational to maintaining public trust in the entire transplant system. It ensures there is an absolute and clear separation between the end-of-life care for a patient and the process of procuring organs for donation. Every protocol we have and every action we take is designed to uphold these two principles without any exception whatsoever. And this question gets to the very heart of the ethical debate surrounding DCD, particularly with advanced technologies like normothermic regional perfusion. When we declare death based on the cessation of circulation, and then just minutes later we restart circulation to the thoracic organs using an ECMO machine, well, what does that say about the nature of that death? Is the cessation of cardiac function truly irreversible if we ourselves are about to reverse it, albeit partially, for the purposes of organ preservation? And herein lies the critical distinction that modern practice relies upon. Irreversible means the heart cannot be restarted. Permanent, on the other hand, means a deliberate ethical decision has been made that it will not be restarted. For DCD donation, we rely on the concept of permanence. The decision not to resuscitate the patient is final and absolute, which then allows us, ethically, to resuscitate the organs, all while ensuring that circulation to the brain remains completely occluded. But even with clear guidelines, we have to acknowledge that this work can take a personal toll. The experience of managing a patient's final moments, declaring them deceased, and then immediately pivoting to an aggressive, technical procedure to resuscitate their organs can be emotionally and psychologically challenging. This conflict is known as moral distress, and it's a very real occupational hazard for everyone in that operating theater. And this really brings us to our final thought for today. The field of organ procurement will undoubtedly continue to advance, pushing both technological and ethical boundaries. To navigate this challenging landscape, we need clear institutional guidelines, we need ongoing ethics education, and perhaps most importantly, we need a culture of open dialogue where clinicians can discuss these complex cases without judgment. Supporting the well-being of the caregiver is absolutely essential to the long-term success of this uniquely challenging and profoundly life-giving role. I appreciate you joining this explainer today. Thank you.